My name is Mohamad Sorror. I work at the Fred Hutchinson Cancer Center. I'm professor of medicine. In this meeting, we presented data on a study that we designed some time ago, where we look at patients from the time of diagnosis of acute myeloid leukemia, when they start receiving the initial therapy, and we followed them for 2 years. And while we're following them, we didn't intervene in the decision about treatment. We only collect information. And we collected a lot of information that other studies don't have the capacity to do that. We were well funded. So we collected a lot of information about patient health, things like frailty, medical problems, people who might have some disability problems, other issues other than their cancer, collected a lot of information about the leukemia itself, and then collected information about how the treatment decisions were made, what treatments were they given, and based on what information. And collected all that information from almost 700 patients that were treated at 13 different leukemia centers in the nation. And then we wanted to see how the social and economic factors played into the decisions made for these patients to receive treatment or not. And the advantage of the study is we have all this medical information and information about leukemia, so we kind of, in our tests or analysis, take this into account, because the main question we were trying to ask is, if somebody cannot get a treatment, is it because medical problem, like they have something that make it ineligible for that treatment, or is it a social problem? And when we did that study, we found that patients who came from neighborhoods where they were lower education level or some surrogates of poverty, for example, needing what's called food stamps or other types of assistance, we found that these patients, first, they were dying more frequently, early after diagnosis of AML. And the ones who survived, they were less likely to receive a curative treatment like the transplant, bone marrow transplant from a donor, which can be curative for many patients with leukemia. We found that the patients who came from neighborhoods where there is lower education or some signs of poverty were less likely to receive that treatment. The ones who reached the transplant and received it, it seems like they did kind of well compared to other patients who came from neighborhoods where there's higher education and higher income. And that made us conclude that it's not really a medical issue. It's a social issue where there are barriers for patients who have lower education or signs of poverty in their neighborhoods for them to reach advanced cancer centers that provide advanced treatment like transplant that can cure their leukemia. And as I said, the unique thing about the study is we have all this information about the health of the patient themselves. So we know if someone did not reach the transplant, it's not because this patient has so-and-so diabetes, high blood pressure, heart disease, lung disease that might make them not eligible for transplant. No, it's because of those barriers, education barriers and poverty barriers. And because of that, I am focused in my future research in trying to remove these barriers or at least make them a little bit easier. And we would like to investigate a lot of things to do that. So we already have a study that we do it with what's called the Bone Marrow Transplant Clinical Trial Network. That's a network that involves multiple transplant centers across the nation, where we creating information, infographics, nice slides, or videos, 2-3 minutes videos where previous patients from the same background talk to future patients from the same background and try to make them trust the system, talk to them about why it's important to be on a clinical trial for transplant. That's one of the ideas. We're also trying to see, well, if we give cash money for some of the patient, for example, would that help them to overcome the barriers to come to the center? Or if we, for example, hire someone navigator that will help them to cross the boundaries of why it's so difficult to do a costly procedure like this, would that help? These are ideas for the future, and we'll need well-funded research in order to prove if it's effective or not. But these are among some of the ideas that we are thinking to do in the future to remove that barrier, because our goal here is we want to reach equality. If there is a promising treatment that can provide cure, we want to make sure it's available for everyone, regardless of their background, race, ethnicity, income, education. It can be available for everyone to achieve the equality that we all seek. We didn't look at that question specifically, but as I was saying, we collected that information. We collected all the molecular and details about the cancer itself, which is leukemia. And when we try to look at the impact of their income and their education, all of that, we kind of took into account how aggressive the leukemia is to make sure that it's not really because of how leukemia is aggressive that they are dying more frequently or not getting to treatment. No, we took that into account, so we are balancing our comparisons for that factor. It's because it's multiple levels. One of them is what you call mistrust in the system. Some patients might not have enough education to trust our system and that we are providing them with cure. Some patients there could be misinformation. So these videos are meant to have a patient from the same background say, hey, I actually went through the process and it turned out to be a good process. So we can remove the mistrust. But that's not the only level, because there is also other things. There is institutional barriers. There is society barriers. There are other barriers that we also need to work on in the future if we want to resolve the problem. I am doing multiple research for patients with acute myeloid leukemia. So other than the socioeconomic factor, I'm also focused on older patients, anyone 60 years or above. So now leukemia is very common in older patients. Median age is 68. Many patients in their 70s will get leukemia, and sometimes it's hard to decide, should we give them a very strong treatment? Should we give them a transplant from someone else? Or that would be too much for them? So part of my research is developing models to tell us if the patient will benefit from treatment or not. Develop studies that say, okay, something called randomized, meaning a computer system would choose if you go this direction or that direction, and build these studies in order, at the end of the day, to provide this information to physicians and patients when they are confronted with leukemia and they are in their 70s. Should I get really aggressive treatment that could affect my quality of life, or should I be less intensive in the way I treat my leukemia and buy more quality of life? That balance, we're trying to build large studies that's done across the nation to try to answer these questions, because guess what? Until now, we don't have good quality studies to answer that question well for our patients. So that's the other aspects of my research that affect everybody diagnosed with leukemia, especially 60 years or above.